Good afternoon. This is part 3 of complications of fractures for med-surg nursing musculoskeletal system. Complications, sooner a fracture is fixed, the less likely the chance of complications. Healing can be impeded because of improper alignment or inadequate mobilization. If this immobilization doesn't occur, then we're having that twisting, shearing, and abnormal stresses will not create a strong bony union. Open community fractures will require surgery. We're going to be doing some antibiotics with the patient as well. These fractures can't actually be created because of calcium and phosphorus if there's inadequate vitamin deficiencies and atherosclerosis. So if we're thinking about infection, we're going to watch temperature, your white blood cell, and wound appearance, because as this occurs, the temperature is going to rise, the white blood cell is going to rise, and your wounds, it will start looking red, swollen, hot, and have some drainage with it. A typical infection would be osteomyelitis. This is from a bacterial infection of the bone caused by Staphylococcus aureus. And this is often related to severe or pain that is very sudden onset. Marked tenderness at the site, high fever, chills, swelling, headache and malaise. Once again, this is telling us this is more of a systemic issue now, not just at the site. Diagnosis. The earlier osteomyelitis is diagnosed, the better. We're going to look at the history of the injury and see if was it an open fracture, did they have boils or fur knuckles or other infections on the skin. We're going to look at the sedimentation rate and white blood cell count. Those two levels are probably going to be elevated. They'll do an x-ray showing something maybe some necrosis or something inside. And the doc may want to do a biopsy to make sure, is there necrosis inside there, and they need to open that up and actually clean it out some more. Treatment. Patients for osteomyelitis, definitely 4 to 6 weeks. If you recall, bones are kind of spongy. They have holes in them and stuff. And so bacteria likes to get into the nook and crannies. So they may have abscesses in there, and they may open that up and allow it to drain. They may understand dead bone is not good, so they're going to go in and debride it. We know that dead bone only aggravates the situation, actually feeds more infection. The limb, the arm or leg, must be totally immobilized and rested. And if this does not occur, or help and healing does not occur, then we're going to go on to amputation. Other complication moving from infection is signs and symptoms. Signs and symptoms of your fat embolism. So we're going to see changes of mental status, respiratory distress, tachypnea, crackles and wheezes. Once again, these crackle wheezes is usually because of inflammatory process that's going on, because you have embolus inside your arterial system causing this. Patient may exhibit a rapid pulse, a fever, some petechiae, like that measles-like rash over the chest, arms, upper arms, and abdomen. Once again, a lot of times this is because the high pressure going on in the vascular system and causing rupture of the vessels. Nursing management, we must stay with the patient. This is where we need, eventually you may be calling code. So putting the patient in high Fowlers, helping with their breathing, giving them a non-rebreather mask, 100% oxygen, crank up the flow meter, high as it'll go. You need to establish an IV, And meanwhile, you should be having somebody calling the physician immediately as well. We can anticipate giving hydration, lots and lots of fluids. We're going to try to flush, open that all up, and so they can get blood flow through there into the vascular system. But they're also going to try to correct some acidosis. Worst case scenario, they'll end up being intubated and placed on mechanical ventilation. The next complication is the venous thrombosis. Now we know blood clots can form because immobilization. So veins of the pelvis and lower extremities are very vulnerable to blood clot formation. So this could be from immobility, traction, casts, leading to venous stasis. So we're going to use compression stockings, SCDs, range of motion on the other extremity to promote blood flow and prevent this venous stasis as we can. The next one is compartment syndrome. Compartment syndrome is external or internal pressure that restricts circulation in one or more muscle compartments of the extremities. This is severe, unrelenting kind of pain. And actually it is an emergency because you need to assess your 6 P's, the pain, pallor, paresthesia, pulselessness, do they have a pulse, paralysis, can they move and then the extremity is going to be cold to the touch because we have clamped down on the arterial supply to the extremity. Here is just a mnemonic here to help you remember this. Talks about compartment syndrome. It's a true orthopedic emergency. Think about your 5 P's. Looking at pressures, looking at the muscle and nerve, because that's what's happening. Compression of the muscle and compression of the nerve to the point where you can lose the limb if we don't do something about it. Treatment and nursing management. Once again, we need to make sure that we are recognizing and immediately notifying the physician to prevent permanent loss. If a cast is in place, they may go in and split it open to allow the pressure to be released. If they don't have a cast, perhaps they're going to go in and do a surgical fasciotomy where there is linear incisions on each side of the limb and opening up the fascia and allowing the swelling to occur, but relieving the pressure as well. Elevation is key to preventing compartment syndrome. Once again, looking at the toes and fingers should be higher than the trunk. Here is a picture of it. So this is an incision on both sides of the leg where they cut through the fascia and opening this up and relieving that pressure as well. Nursing management, once again, assessment. Initial assessment, we need to know what is the mechanism of injury. The physical assessment, we need to do special considerations of open fractures. You know, knowing open fractures here are problematic. Implementation, maybe it's cast care, fiberglass, comfort measures. Remember, on cast care, we're not going to handle a wet cast. We're going to allow it to dry. It should be warm, but we've got to make sure we're going to assess, is there enough room in the cast, positioning and repositioning, and making sure you teach the patient about itching and skin care as well. We don't want him shoving stuff down inside there because it itches, because that can actually cause more trauma than it's worth. Evaluation. Once again, we're going to evaluate the pain. Should be under control. Over several days, that pain should be gone. If there's more pain, then possibly Is it an infection, osteomyelitis, or is it compartment syndrome? Once again, progress toward independent ADLs, leg or arm. They start to adapt to how they need to manage that and go on from there. Assess for skin breakdown, constipation, atelectasis, or DVTs. Once again, this is problems from immobility. We need to assess for that, evaluate. Our treatment measures, are they working for these? We're going to evaluate, did they have other complications of infection and compartment syndrome? If not, we're good to go. If the goal is not being met, the plan should be revised.